Thanks to everyone for coming to our 5th NSTS lecture. Today's lecturer is Sam, who is a senior registrar in colorectal surgery at Addenbrooke Hospital in Cambridge. He has special interest in medical education, robotic surgery, advanced pelvic surgery, and improvement of healthcare systems in developing countries. He also has been teaching medical students in Somaliland through an online platform for almost a decade. So he's very experienced. And we hope you will find it very useful. If you have any questions, please use the Q&A function rather than the chat, and we'll keep an eye go through. And without further ado, I'll pass over to Sam. Thanks very much.
Thanks a lot, Kate. Thank you much for everyone to join in, and I think this is a really good platform to learn your surgical knowledge, improve your surgical knowledge, particularly as a house officer and as well as for your finals. I hope what I'm teaching today will help you to help you in some way. So what I'm going to talk about today is the important things like colorectal cancer, as well as we will go through important day-to-day colorectal cases that we see in the ward or when you're on call. So my objectives today are to discuss about the scope of practice of a foundation year 1 doctor, and also we'll talk about a little bit of anatomy and colorectal cancer and benign conditions. If you have any questions, you can ask me at any time, but I will try to answer all of them or as much as possible at the end of the lecture. Hopefully, this shouldn't take long, but we'll see how it goes. So when Foundation 1 house officer, if I one doctor is a very important member of our surgical team for sure, because if you don't, most of the hospitals I've worked, this is the first job you're going to do your night shifts. So you will feel the proper call phase of the surgery or the medicine, particularly during the nights, because most of the time you are a sitter and the registrar will be in theatre or in A&E seeing patients, and you'll be called left, right, center from all the wards about sick patients and various fluid prescriptions, medication, you name it, you will call for everything. So it's very important before you start. So when you finish your final exams, and when you do just before you start the job, you shadow your house officer for a week. I would really suggest for all of you who are doing surgery or going to do surgery as their first placement, just go with him on one night and see how he or she deals with things and what to expect as a house officer, so that you know what's coming ahead, and that helps you to improve your confidence as well as you know what to expect, so there won't be unpleasant surprises. And so duties of surgical house officer varies from whether you're on call or whether you're covering wards or your day-to-day job. So I'm not going to go into details about it, but when you're on call, you will be the first contact of the patient's care, and you will be the one who's calling shots to say what to do with the patient's initial management. So your role is very, very important for us. And I'm as a registrar and as a consultant, we completely rely on your the information you are giving us, and the patient's subsequent management. Everything, including life-saving surgeries, will be dependent on what you find from your patient's history and examination. So don't take it light. At the same time, you don't think you're not very important. In actual fact, you are one of the, I would say, in my mind, you're probably the most important person in the team. Okay, and so clinical skills wise, I think most of us now relying on nursing staff who achieves to do NG tubes and cannulas and catheters. But it's very important from beginning of your career, if you learn how to do a NG tube in a quick session, or try to learn how to do tackle the issues with NG tubes, because I'll tell you, when you start the job, it won't be long when you've been called to see a patient where the nursing staff cannot do an NG tube, someone who's got obstruction where you've been asked to do NG tube urgently. So if you're not confident enough, or if you haven't done enough NG tubes or nasogastric tubes for these patients, then you will really struggle. And that step itself can save patients' life from aspiration and subsequent pneumonia and all the other complications. So it's always good practice how learn how to do an NG tube, do difficult arterial blood gases. Particularly, even most of us are not quite equipped or experienced enough to do femoral stabs. So those things, even if you're not doing it by yourself, at least ask your registrar or someone senior to show you how to do it, and at least have a couple of goes just to make sure you know what you're doing. Because the person you can't do a radial stab, that means he or she will be very unwell. So then you need to know how to do a quick ABG on these patients. And cannulas is a no-brainer. Everyone has to do cannulas, and everyone should know how to do difficult cannulas. And don't shy away from it. Okay, if you, it doesn't matter whether you fail, well, not on the same patient, but if you fail 5 or 10 times, then you know that something's not right. Then what you need to do is you need to ask someone, or could be one of your colleagues, or could be one of your seniors who are really good at doing cannulation. And best people I learned to do cannulation is anesthetists. They do thousands of cannula a year. So you just see how they do it and how confident the way they hold the cannula, and just learn the technique from them, and that will take you a long way. So and be confident about it. The more you do it, you're gonna better at it. I know when you're a house officer, you've been asked to do hundreds of jobs, but these clinical skills are essential, and those people who do it better will shine out quite quickly, and then it will take you a long way, right? So cannula, catheter, and in nasogastric tubes, and get arterial blood gas. Those are the four main clinical skills we would expect from you. If you're really keen and if you're interested in surgical or trauma management, then of course you can at least have a go on central lines and chest drains. But I don't think it's necessary at this point, apart from those four the ones I told you about. So we'll directly go to scenario. I got on two scenarios. I think where we can discuss in length about most of the things that we want to know as a surgical officer. Today I'm going to talk about the colorectal in related conditions. But bear in mind, last week we had pancreatitis and other related surgical emergencies. I would think this will cover most of the day-to-day bread and butter cases you will see in general surgical intake. So the scenario, first scenario is you're the house of fire. I'll give you about 2-3 minutes to gather your thoughts, but also you're the foundation. You're one house of a doctor on call. Emergency department calls you because your registrar's not answering or someone's not picking up the bleep, so they call you because they know you. A&E knows all the bleeps, so you can't shy away from it. So A&E refers a 72-year-old gentleman who's coming with fresh rectal bleeding, and now the patient feels very well within himself, and he thinks probably it's bleeding coming from hemorrhoids. Now he wants to go home, but A&E is not giving up, so they want a surgical consult for this patient. I think quite rightly so. So, um, so you unfortunately your registrar is having a coffee in the mess, and he doesn't think this is up to his pay grade, so he wants you to go and sort out the problem. Okay, so this is not the reality. Okay, we all work hard and nobody's inferior or superior. So, but I thought just to add a little bit of a fun fact, so I just put this scenario. Now, these are the details A&E doctor tells you. A white cell's normal, CRP is normal, HP is 11.5. So for a man, this is slightly anemic, and urea electrolytes all normal, and MCV is 75, MCH is low. Lactate is 1.4. When you look at it like straightforward, it doesn't look that bad. So have a thought about 30 seconds and tell me what you're gonna do. Okay, you can either put out chat messages like briefly one or two things, or what we can do is we can discuss at the end. I'll give you 30 seconds to think about it. Okay. All right. So this is the believe or not, these are the day-to-day cases you will see. Like every on call, you will see at least one or two patients with rectal bleeding. It could be various types of bleeding. It could be dark or altered blood bleeding or fresh blood bleeding. Uh, uh, when you look at it straight away, what draws my eyes is this patient is anemic for sure, and then the patient is hyperchromic and microcytic. So these are like telltale signs for us to concern whether the patient has got something else going on, or whether the bleeding has been going on for a while but he's been ignoring. And he's a 72-year-old gentleman. So when you go to the patient, every scenario, doesn't matter whether you see hundreds of patients, is history, examination, and investigation and management. So for the history, what I would ask this patient straight away is whether how long has he been having this pain, bleeding, and was it fresh bleeding or altered bleeding. So you need to verify and clarify whether what kind of bleeding, and you need to differentiate from melena. And whether the patient is then having large amount of melena followed by fresh bleeding, then that tells us the bleeding is coming from further up rather than the colon. So then you need to get the other like people like gastroenterologists involved for this patient's management, because it's most likely patient is suffering from upper GI bleed rather than lower GI bleed. So first of all, you get the decent history. In that, you have to differentiate whether the patient has got upper GI or lower GI bleed. So the lower GI bleed could be fresh bleeding, altered blood, or blood clots. So hardly you see melena on these patients, and it's very rare to someone to come with lower GI bleed and present it as a melena. So, and then number two, you need to check what type of bleeding is this, whether the blood mixed with stools or the fresh blood, or whether you see a splash of blood in that commode. So splash and painless and either it's painful bleeding or painless bleeding. So most of the hemorrhoidal bleeding is most of the time is painless bleeding, and you will find like a splash of blood in the commode. And uh, pain associated with bleeding most of the time is associated with anal fissures, where you find a bit of a crack in the anal canal, which causes the pain and discomfort along with bleeding. So, and there are four cardinal questions you need to ask from everyone who's coming with, particularly with general abdominal pain, but anyone coming with rectal bleeding or PR bleeding, you have to ask whether they have got any loss of weight, whether they have got any loss of appetite, whether they have got any change in bowel habits, and whether there's been associated abdominal pain. So all these four questions you have to ask from any surgical patients, anyone coming with abdominal pain, because these are telltale signs there's something wrong with these patients. Okay, and uh, anal fissures. So the pain is associated with anal fissure rather than anal fistulas. You won't get much bleeding from anal fistulas. So the anal fissures is essentially a bit of a crack in the anal canal, where you will find that the patients are coming with severe perianal pain with some blood is not very prominent, but but you can see blood with blood with stools, blood with pain, and patients coming with left iliac fossa, abdominal pain, very important that you need to ask. The questions you need to ask again, duration of the condition, and whether he or she has taken any undergone an investigation for that, because this patient might already had a colonoscopy or a flexible sigmoidoscopy. Someone has already been investigated this patient, then you're wasting your time. So you know, if it's within last 2-3 months or 6 months, then you know this is already ongoing problem, and if the patient is stable enough, you can discharge the patient. Now, examination is very important. We all forget how important the examination is. So in examination, you we are quite quick to go to abdomen, but don't forget you can see the palo, the icterus, and the cervical lymphadenopathy, supraclavicular lymph nodes, the Virchow's nodes. You have to always check those and check the patient's pulse. If you don't see if you don't have the patient's latest clinical parameters like blood pressure, pulse rate, then it's always better to check the pulse. Whether the pulse there's a good volume of pulse, and whether the patient is tachycardic. So then you know how to manage which patient, and you can plan ahead what to do next steps wise. And when it comes to abdominal examination, I don't need to tell you, but super inspection, palpation, percussion, auscultation doesn't it doesn't matter how senior you are, you still follow the same principles. Okay, there is nothing, there's no escape from that. These are time-tested methods, and you have to follow that. So clinical examination, what you're looking at is patient abdominal pain, the masses, whether you can feel a mass, or whether you have to, whether there's any tenderness. When there's tenderness, back in the day, we all used to do. Uh, we all used to do rebound tenderness. We don't do it anymore. Uh, uh, we we what we do is now is we do percussion tenderness. All you have to do is just go to the area and then lift the other fingers and just tap on the middle finger, like do any percussion, and that will tell you it's just any peritoneal irritation. So if they have percussion tenderness, that's a good sign that the patient has got localized peritoneism. That could be due to infection, inflammation, or it could be just a tumor perforation or any other complication related to the peritoneal irritation. So you need to, if you feel or if you get these clinical signs, then don't forget that you need to assess something urgent and treat them quickly. And one thing we all forget, the two things we all forget is the examination So it doesn't matter how convincing patient is or patient is not keen. So you have to convince them to make sure that you explore them properly and examine the groin. So particularly if you have anal cancer or lower rectal cancer, you can find that the lymph node infiltration is into your groin. You have to make sure that you examine. If you feel lymph nodes, then you know there's something's not right. Then you need to you can focus your examination and management furthermore. Okay. And anyone coming with right iliac fossa pain, I always, or left iliac fossa, particularly with younger patients, I always examine their genitalia, particularly their scrotum and testicles, because they can have testicular torsion, and all of a sudden you find that you miss testicular torsion because the patient is only complaining of abdominal pain. Right. So make sure that you examine the patients properly. And then the digital rectal examination, don't think it's a registrar or SHO job to do a PR on these patients. Don't be afraid to do a PR on these patients. And if you think that the patient's got a tumor, and if you felt a tumor in a PR, you will never ever forget that. Okay, so then and it will give you confidence. So when you're doing the PR, the things I will always look at is first inspection whether there's any external polyps, prolapse, or external hemorrhoids that you can see. And then when you put your finger, you can assess the sphincter tone, and then whether you got any if the patient has got any severe tenderness, that's a sign that the patient has got a fissure or not. And then with your fingers you can feel the prostate and feel whether there's any enlargement, whether you can feel the median sulcus of the prostate, and the skin over the mucosa over the prostate whether it slides nicely, and also whether you can feel any masses or any other abnormalities. And more also you can assess the quality of the stools. With they have some people come with really low abdominal pain, and when you examine left or left fossa, you feel a massive mass, and then you think, oh god, this is patient has got a big tumor, so we need to go and quickly do a CT scan. But if you haven't done a proper PR, you will find, if you've done a proper PR, you will find that the patient has got really bad constipation. You're just feeling the hard stools. So you can assess the quality of stools. If the patient has got really bad hard stools, that could be the reason for the patient's pain. Then you look, once you've done everything, you take a finger and have a look at the glove finger. Never ever forget to look at the glove finger. They might not be bleeding heavily, but if you look at your finger, you will feel some altered blood, or you can see fresh blood. That's a good marker. to assess the patient's PR bleeding levels. And then when it comes to differential diagnosis, you need to think what are the differential diagnoses. For this patient, I would, without anything, without an examination, my first differential diagnosis, I want to see whether this patient has got any cancer. So then the next question is whether do you want to investigate this patient as an inpatient or outpatient? Okay, if the patient is well and hemodynamically stable, there's no pain, no other abnormalities, and if he's not actively bleeding, then you can safely discharge these patients. But if he got severe abdominal pain, increased inflammatory markers, you have to think about conditions like acute diverticulitis, colitis, and then if there's no other problems, then you can think about if you've seen the patient has got distended abdomen, you have to think about conditions such as say volvulus, etc. So what for this patient, the main aim is you can't miss a cancer, so you want to examine this patient, investigate this patient further. So investigation wise, I would say he's a 72-year-old gentleman. He's generally fit and well, so he can easily go for a colonoscopy. So I would book this patient what we call 2-week a colonoscopy or a flexible sigmoidoscopy under 2-week wait pathway. So the 2-week wait pathway is a 2-week wait pathway is what we call a cancer pathway. Essentially, the cancer pathway, the patient will get expedited services without delaying any investigations. So they will, what you can do is you can get a flexible sigmoidoscopy or colonoscopy for this patient. Given that history of abdominal pain, what you can say is you can get a CT scan of abdomen pelvis with contrast, so that you can assess the extracolonic organs as well as the colon. So the bleeding may be coming from his diverticular disease, and then you can assess these patients properly. Now, someone asked the question, why if percussion tenderness favorable from rebound tenderness? You should see someone who's got rebound tenderness. It's really, really painful. So, and if you see, if house officer, registrar, and the consultant, all three of them try to do a rebound tenderness on this patient, the third time might end up with a slap because it's really painful. So it's always I think that the kinder way to assess peritonism is the percussion tenderness, and you can definitely get an answer for that. Okay. All right. Excellent. So we'll go to the next slide, and then follow up. Obviously, for these patients, follow up depending on the findings. Right now, this is a very busy diagram, but all I want to tell you is there are a couple of things. So you've got your terminal ileum coming to the cecum, ascending colon, and then this is your hepatic fracture, transverse colon, splenic fracture, and then you've got descending sigmoid, rectum, and anal canal. These are the main important parts for us. Now, as a surgeon, I am very interested in not only the bowel where it lies. My money is on the bowel, blood supply to the bowel. So wherever we operate, we take parts of the bowel depending on the blood supply to the area. Now, the main reason we are focused on the blood supply to the bowel is that's where the cancer, along the vessels, major arterial vessels, where the cancer spreads. So you want to make sure that the lymph nodes are spread along the lines of the blood vessels. So you need to make sure that you take the adequate amount of vessels. So the right side, right left, so the ascending colon and the cecum is mainly supplied from the ileocolic vessels, and then the right branch of the middle colic. And then the left side is mainly supplied from your left branch of the middle colic and the inferior mesenteric artery. The rectum has got two different blood supplies. You IMA supplies you superior rectals, and then you get your middle and lower inferior rectal vessels coming from pudendal as well. Okay, and so that's where it's important that you need to know the blood supply. Also, that's related to the lymph drainage of these patients. Okay, so the colorectal cancer is a very, very important type cancer, where is the fourth common cancer in the in UK, and it is still the same. Not only 2014, I think I saw the Cancer Research UK recent article. It's the same, the third fourth most common cancer in UK, and it's quite prevalent as well. So and one of the reasons is we see day to day. It's because there we got really good cancer screening programs. So there are three different cancer screening programs. One is Flexi 55, where you get uh, uh, flexible. Everyone's getting a flexible sigmoidoscopy at the age of 55 because the left cancer colon prevalence is higher. And also we have the fecal or cult blood test. This the old one where we send us two different stool samples, and this test for blood cells in the stools. And then now the newer, and I think which will replace the fecal or cult blood, is your fit test, where you will looking at immunohistochemistry of your blood to see whether there's any that gives us a telltale sign whether the patient has got a polyp or a tumor in the bowel. It's got a higher sensitivity and specificity rate as well compared to fecal blood. Now, so this is somewhat controversial. At the same time, I think it gives you a bit of an idea. If it's left-sided, the patient's mainly coming with changed bowel habits and pain and somewhat altered blood. If you have right-sided tumors, patients mostly come with pain and change in bowel habits, along with darker, more altered blood. And the fresh blood oil is most of them associated with rectum or low distal sigmoid area. And so this tell us that how often and how what's the frequency of these patients coming with. And the one thing you need to understand is, like, if the patient is coming with obstructive tumor, so you've got obstructive tumor here, right? And then if you have a competent ileocecal valve, all of a sudden this area is going to be a closed loop. So these are the group of patients we have to be really careful, and we have to assess properly and manage quickly, because it's a closed loop obstruction. The thinnest area of the colon is your cecum. If you know your lower Laplace, the pressure on these walls are quite the dilatation of the bowel goes quite quickly, and if you will see the bowel, the cecum dilatation quite significantly on these patients. So if you look at the CT scan, we say the cutoff is there's a 3 centimeter rule, 3, 6, 9, and 12 centimeters. So if you see a cecum about close to 12 centimeter, it's almost impending perforation. So you have to be very careful. So someone asked a question about higher sensitivity fecal occult, but it's the FIT testing. Okay, so FIT, and essentially, so if you have an incompetent ileocecal valve, that means that even if there's a blockage, the air or the pressure can some of the pressure can dump into the small bowel. So these patients coming in both large bowel and small bowel obstruction, and those are the people who will benefit from an NG tube, definitely, because you can decompress the part of the bowel by using an NG tube. It is a bit controversial that whether you put a NG tube for a patient who's got a competent ileocecal valve. Number one, you will not know that the patient got a competent ileocecal valve or not until things get worse. So there's no harm putting an NG tube. And this number two is, even if you have a competent ileocecal valve, that means if this ballooning up now really badly, this area will have a pressure effect on the stomach. So as you would know, that the stomach produces about 800 mils to 1.5 liters a day. So there's even for those patients, still you should put an NG tube, because because of the gastric outlet obstruction or the pressure effect on the stomach is quite high, so that the patient will have problems. Okay, so that NG will be very, very important for these patients. And majority of the cancers we will see as a house officer is on the left side. That's why everyone at age 55 getting a flexible sigmoidoscopy, and the right-sided cancer is not that common in this area. So NG will relieve the pressure if the patient has got an incompetent ileocecal valve, and secondly, if you have a competent ileocecal valve, that will still help to improve the gastric outlet obstruction or the pressure on the stomach. So NG is very important. Now, this is a graph, I think is a bit beyond your level, but something I just want to tell you about why we do the certain investigations. So suppose you got someone who's coming with left side fossa pain or abdominal pain. Why do you want to do CT scan? This chart shows up to 50 years, the cancer prevalence is not that common. But after you pass, as soon as you pass 50-year mark, you find that the prevalence goes double, almost triple when you come to 60s. So it's very important. It is very important that you investigate these patients with a CT scan of the abdomen pelvis when they come to hospital with abdominal pain, because you can justify. So you call the radiology registrar, and for some reason, if the registrar says, "Why do you want to do a CT scan on this patient? His blood looks fine, abdomen soft, but you say there's tenderness in left fossa. Why do you want to do a CT scan?" You can say, "Look, he's a 70 or a 60-year-old or 70-year-old gentleman. He's a high risk patient for a colorectal cancer. I think it's worth doing a CT scan to make sure that we're not missing anything serious." And so someone asked why the left side of the colon cancer is common. The answer, I really don't know the answer. I don't think any of us knows the answer, but I think it's part of it is one of the reasons is the part of the bowel which goes into majority of the pressure changes is in the left side, and so the bowel function changes and varies with this area. We got so many theories. I don't think anybody really understands why left side is common, but it is always multifactorial. One is the bowel function, and the pressure areas is quite high on that side, and the bowel the gut colonization is different in that area, as well as I think the cell damage is quite high in that area, so that it leads to left-sided colon. But don't quote me on that. Okay. All right. So the majority of the patients are sporadic cancer patients. That means you don't have a clear-cut reason for them to get it, but they are in the risk group, and then they get cancer, and then you get familial cancer, and then familial adenomatous polyposis and hereditary non-polyposis or Lynch syndrome patients can also forms about 6% of the cancer patients. Right, now I'll quickly touch base on principles of management. Surgery is the main treatment. That's one of the advantages of being a colorectal surgeon. We are curative surgeons. That means we don't do a part of a job for someone else to complete the rest of the work. So complete removal of the tumor with negative margins, that means R not resection, is the thing what we are looking at. Now, the only reason I put you for this slide, I think it's partly beyond your level, but one thing you will be asked this question in the ward by the patients, because we do all the fancy surgery and patients go to the ward, and all of a sudden you find that the patient calls you and asks, "Doctor, what is this? Why did you do this pressure operation? Why did you remove this much of the bowel from me?" If you have a general understanding why your surgeon or the boss did this operation, then it's very easy to talk to this patient, because at the end of the day, you are the person who will be in the unit for 24/7, and we are usually visiting, coming and going. So you'll be asked so many questions by the patients and the patient's relatives. Even the ward nurses sometimes ask you questions. It's better to know why we're doing this. Okay. Okay. So So the stage 1 cancer surgery alone, and stage 2 onwards we do chemotherapy and metastatic release, metasectomy. Now, One other thing is what you need to know, what are the types of operating we are going to do. So there are four common names you will hear when you're in the surgical end. One is the right hemicolectomy. That means we are going to take the part of the terminal ileum, right, and then we'll go up to around here, and then you will sacrifice the ileocolic vessels. Sometimes you take the left branch of the middle colics. Okay, now that's the right hemicolectomy. And then what the other thing you will hear, that's done usually for patients who got cancer, is from cecum to transverse colon. Now you might hear a word called extended right hemicolectomy. That means if you have a tumor in the distal transverse colon, you do the same operation, but you go a bit lower down where this is just splenic flexure. So you mobilize the splenic flexure and you cut about somewhere here, and then you bring this bit to here into the terminal ileum, and then you do a primary anastomosis. You will hardly see in a stoma for these patients who are undergoing uh, um, uh, patients who are undergoing for right colectomy. Now, past few months, because we had the severe COVID, when we had the higher peak of COVID-19 pandemic, we didn't join these patients purely because if you get COVID-19 while you're a post-op patient, the outcomes are poor. On top of that, if you have anastomotic leak, then the chances of you surviving is very poor. So for those reasons, we didn't join the patient, but and we always try to join these patients. Okay, and then the second operation you're gonna hear is the right hemicolectomy, or the high anterior section. High anterior section is usually done for patients who have got tumors in descending colon and sigmoid colon above the peritoneal reflection, or above the pelvic rim. Okay, so high anterior resection is essentially done for sigmoid and descending colon and upper rectal cancers. What essentially you would do is you will again go up to here, you disconnect from here, or you come here, and then you mobilize this bowel and you bring it down and join to the rectum. Okay, so that is done usually by a end-to-end staple anastomosis. So we hardly do hands-on anastomosis. Everyone's getting staple anastomosis these days, and there's no evidence to say that the adequately performed staple anastomosis is inferior to hands-on anastomosis, right? So overall, if you take the anastomotic leak rate, you should expect around 4% for these patients. And the third operation you're going to hear is the low anterior resection. Essentially, that means the patient has got cancer in the distal or middle or distal third of the rectum, where you're going to go all the way down here. You chop this bit of bowel, and then you mobilize the bowel and take this bowel. So again, for the left side of cancer, your main vessel is your inferior mesenteric artery. So what you do is you go all the way down to the origin of the inferior mesenteric artery, and you chop it there. So that's called a high ligation, and you can go low ligation. So it's a bit like controversial when you say high ligation. That means that's very close to the aorta. Okay, and you do it just to get the proper lymph node yield. Okay, you would expect about 10, at least 12 lymph nodes when you take sample. And when you do a low anterior resection, most of the time, I would say 70 to 90% of the time, you will end up having a ileostomy. So the patient will have a right side, right or left fossa, and ileostomy for this patient. And then the fourth operation you will hear is the abdominoperineal excision. That means you go all the way down, you chop this bit of bowel, and you take the bottom out completely. That's purely because the patient has got cancer in lower down, you don't have enough tissue to do an anastomosis, or the tumor is involved in your sphincters. The other group you won't do anastomosis if you have really poor sphincter function before coming to the operation. That means someone is suffering from incontinence, and then there's no point of doing an anastomosis for this patient. You will end up having more problems. Okay, so the right hemicolectomy, uh, high anterior resection, and then low anterior resection, and then you take APR, abdominoperineal excision. So abdominoperineal excision patient will end up having an end colostomy on here. Okay, so they will end up having an colostomy on the side. Now we do palliative procedures. Sometimes you will end up having a higher or transverse colon colostomies purely just to buy time for these patients. For example, the patient has got obstructing tumor here and then multiple liver metastases. You don't see, they don't have a really, they have poor prognosis. What you do is you just avoiding and future obstruction or ongoing obstruction, getting a stoma proximally. Okay, that's purely for functional purpose rather than curative purposes. Okay, now this is the most important bit for you guys when you're in the uh, uh, so very important for you when you are in the ward enhanced recovery program. Okay, so this is been here for ages. Back in the day, we always used to keep the patient fasting for about 4 or 5 days, and then we found that it doesn't make any improvement for patient's outcome, as well as it reduces the patient's nutrition levels really badly, and we always wanted to, and then it increases the risk of anastomosis. Now what we do is we let everyone drink water up to 2 hours before the operation, and they will have what we call carbohydrate loading. They will get a carbohydrate rich drink to about 3 4 hours before the operation, and then they will have it, most of them have it at home, and then after the operation, unless we see otherwise, everyone gets to eat and drink just like normally. Okay, but you don't go to town with food, and no 3 course or 5 course or 7 course meals. You get the soft diet and eat and drink and normally and see how things go. Unfortunately, there's about a good 10 to 20% of them will go into IDS. That means they will have nausea and vomiting after the operation. Then once we pick those group of patients, we won't let them eat and drink, but we are conscious about the nutrition. They will end up getting parenteral nutrition. So as an house officer, it's your duty to look after these patients and notice who's going into ILS. And first of all, they all should get near a nasogastric tube, and you need to prepare them for their fluids and other things. Now, third one, then once you see this patient, you need to remember, you need to make sure that they get nutrition adequately, parenteral nutrition, with so particularly preferably through a PIC line. Okay, so and also liaise with your physiotherapist. Make sure your patient walks up and about really well. Okay, so you know the type of surgery, and then you know the types of stomas, and very important that you keep an eye on the stoma output. Anyone who's going above 1 liter, you need to keep an eye on, particularly for ileostomies. They are quite notorious to go in a massive output. I've seen patients going up to 4 or 5 liters a day. That's really difficult to manage. So there is a separate high stoma output management. I think if I have time, I'll talk about it. But what is most important for high stoma output patients is you're maintaining a proper input-output balance, as well as correcting their electrolyte imbalances, and make sure that the patient stays well hydrated. And also for high stoma output patients, don't forget they need their nutrition. So even if you don't eat or drink, you still end up having your gastric and pancreatic secretions will be there. So you need to make sure that they get hydrated very well with nutrition. So the immediate complication for any operation is bleeding. So you need to make sure that their hemoglobin levels are stable. If any patient has got massively hypertensive, hypotensive, and tachycardic and tachypneic, then you need to make sure you escalate your care. Number one is very important. It's always good to look after these patients, but sometimes when it's busy, we all go into a bit of a tunnel vision. So don't ever do that. To manage the patient at the same time, don't forget to escalate the care to your registrar or anyone SHO. Even if you can't get hold of any of them, don't be shy to call your consultant. Okay, nobody's going to bite you, nobody's going to shout at you for calling any regarding a worrying patient, because if that culture has long gone. And I would really appreciate my fund calls me and tell Sam, this patient doesn't look right. I've done these things. Can you come and review this patient? If I can't, I will make sure what the things that you need to do at the same until I come and see the patient. And if I can, I will always run and see this patient because I trust your judgment, and we all rely on your assessment and management. So they don't be shy to assess these patients and do the right thing about it, and don't be afraid to escalate as well. Okay, that's not a sign of a weakness. I think that's a sign of very good lateral thinking. And ileus and obstruction we talked about, and sepsis. Obviously, if they have an anastomotic leak, then you have to be very quickly assess this patient, and everyone who's unwell use the ABCD approach, and make sure that their oxygenation is well, and their volume, if their volume depleted, don't feel shy to give IV fluids vigorously, provided they don't have any heart failure or any other severe comorbid conditions which will cause problems with if you overload them. And thirdly, start antibiotics. Okay, if you think someone is septic, if they are throwing off fevers, if the infection markers are raised, stick to hospital guidelines and start the appropriate antibiotics. Okay, nobody's going to penalize you for starting antibiotics, and it's the right thing to do, because there is good evidence that if you delay the treatment or if you delay antibiotic treatment for these patients, the outcomes are poor. So if you find think, or if your registrar thinks or the consultant thinks that's inappropriate, we can stop it. So it's not a problem at all. So sepsis and leaks are go hand in hand. Um, Most of the leaks nowadays, if it's a small leak, you can manage conservatively, i.e. by just antibiotics or radiologic guided drainage insertion. If you're going, if your team is thinking about radiologic guided drain insertion, next thing should come to your head is this patient should have a plotting done, because the first thing the radiologist will ask is why, what's the patient's PTA PTT. Okay. So there are two questions I've got asked. So what I will do is uh, 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 if someone asks the high storm output, yes, you can start on medication such as molnupiravir, and then you should start something like omeprazole or lansoprazole or PPS. Usually gives reduce the gastric motility and the gastric secretions. That will reduce the output as well. Okay, and loperamide, you can go up to 16 milligrams QTS. That's a very high dose, but it won't do any problem at all. And particularly patients who are on steroids, make sure that you give them adequate IV dose, because that's really important. Because one thing you will see time and time again is you will see patients who are going into Addisonian crisis, where they suffer from massive adrenal insufficiency, and all of a sudden they come with hypotension, tachycardia, breathlessness. Then you think about sepsis and various other things, but it just escapes your mind that the patient has been on steroid for COPD or various other conditions for ages, and then suddenly someone stopped for some reason after operation, and then you didn't realize the patient is going to Addisonian crisis. So whenever you are assessing a patient, make sure that you look at the patient's blood chart, look at the patient's past medical history is very, very important. Okay, and so uh, if a patient asks you what sort of follow-up I'm having after the operation, they all will have 6 monthly tumor marker CEAs and done, and then they will have 2 CT scans and one colonoscopy at the first year, and then fourth year anniversary of the operation. Okay. Um, okay, so I will go to the scenario 2. So second patient is a 48-year-old presented with severe left iliac fossa pain for 3 days, and no PR bleeding, no nausea, vomiting. This, clearly the patient is tachypneic and tachycardic, and the patient is septic. So high white cell, CRP. So, and it doesn't look like a patient, a small patient either, right? So anyone who's coming with this kind of clinical presentation, you need to, that's the patient you're going to see first. Okay, doesn't matter, any refers you 5 patients. So if I have this patient and the other PR bleeding patient, doesn't matter whether the any refer that PR bleeding patient first. This is the patient I'm going to see first, because this is the one who needs our attention urgently. Okay, number 2. So unfortunately, your registrar again in acute queue for the COVID-19 antibody test. He doesn't want to lose his spot, so you work in a really bad hospital, so you've been again asked to see this patient by this lazy registrar. So halfway down on your way to A&E, then registrar calls you that the patient's going to A&E ED resus, right? He wants you to run. Look at the guts of this guy, okay? So you have to now run and see this patient. First of all, you don't have to go through any of those nonsense like that, okay? Nobody should treat you like that, but I'm just for fun I said that, but just to show the emergency and the importance of this patient. So first of all, any patient, you do your usual ABCD approach, and then you go to your history examination management. So for this patient, is clearly this patient has got severe sepsis going on. History, you need to ask how many days this is going on, and if the patient stable enough, then you whether they had previous episodes like this, whether the patient has got any medical comorbidities, and whether the patient had previous investigations, and etc. etc. Examination. Nothing changed. Same examination. I would clinically examine this patient. An abdominal examination, you find generalized peritonealism, but more on the left iliac fossa, and then the patient is guarding, there's rigidity, and the patient is in massive severe amount of pain. If the patient is stable enough, I will still do a PR examination just to make sure that you're not missing anything serious. Okay, and so you can do a quick PR examination on this patient. The differential diagnosis exactly same, right? These are bread and butter of your general surgical management. Number one will come to my head will be the patient has got acute complex diverticulitis. Has the patient has got ischemic colitis, whether the patient has got bowel perforation secondary to obstruction, has the patient got ischemic bowel, whether the patient has got a this big patient, clots, blood clots can be a possibility. So you can think about ischemia, lactate is 2.4, and then obviously tumor and tumor related perforation also should come to your head. And then always don't forget when you get, that's very important, that's why you need to get a good history. The patients can come with C. diff, Clostridium difficile infection, because they must have been on antibiotic for a week for some chest infection. All of a sudden find this patient's coming with C. diff, colitis, but there is a condition called toxic megacolon, where they have massive colon about to perforate. That can give you a very unwell patient with this ongoing sepsis. Investigations, your routine bloods. If the A&E has not done these bloods, make sure they do it, and always make sure that this patient can go into theater. So make sure that you have got enough group and saves. So the hospital I work, you need 2 group and saves. I think that's the case for anywhere in the country. So make sure if they have only sent 1 group and save, send the second group and save, and make sure that they got clotting done, because if the patient needs to be part of sepsis, your clotting can be deranged. If it needed to be corrected, you need to action on it quickly. Okay, and this is a CT scan. There's a nasty diverticulitis with a localized perforation with a collection. So these patients, I don't think this patient needs to go to theater urgently. If you resuscitate properly, then you can drain these collections. When I say resuscitation, uh, the most important thing as a house officer is, I would say that there are 3 things. One, make sure the patient's airway, breathing, oxygenation is adequate. Number 2, the fluid resuscitation for these patients, and number 3, antibiotic treatment, and then number 4 is your escalation of care. You have to escalate this care. As soon as you see this patient, do the initial assessment, call your registrar. You have to come to the A&E right now. Okay, you say that in authority, and you tell that in with all the information in hand. Okay, right? Don't get panic, but while until your help comes, you need to make sure that you utilize your A&E. Okay, one bigger problem I've seen A&E is as soon as they refer a patient to you, the patient is pretty much just your baby. Okay, so you have to look after everything, you have to do everything by as you go along. So my what I would do is, so stick to the I think your last lecture was about how IV fluid resuscitation, how you manage these patients. So I'm not going to go everything one by one, but this nice protocol. It's a very informative, and it gives you all the information that you need to assess these patients and how we manage these patients. Now, resuscitation fluid, heart burns. That's it. Nothing else. Okay. Don't think about anything else. Unless the patient is massively hyponatremic, then you can give a normal saline. But in any money, no, but you can't get it wrong. You do heart burns fluid resuscitation. You give 500 mils bolus. That means within 40, 15 minutes, then you give another bolus, and at least you can go up to about 2 liters without fear, provided the patient doesn't have a heart failure. Okay. And make sure uh, if if you press once you prescribe the fluid, make sure that the A&E nurses, until you sort out the fluids, they need to run and get a catheter for this patient. Input output monitoring is very important for these patients, because your subsequent fluid resuscitation and management relies on how much fluid you give this patient, how much urine output this patient is getting. And then you make sure you give antibiotics properly. And if the patient is severely unwell, I would use proper snake venom antibiotics. Okay, that means the stronger one. So if the protocol says Cormoxiclav, you can start with Cormoxiclav, but you can have something broader, broader spectrum, something like uh, um, tazocine or piperacillin tazobactam. Okay, and probably the patient is not allergic. Okay, so for your resuscitation fluids, input output chart, catheter, uh, uh, then make sure that you reassess this patient again. Okay, and so just because you prescribe the fluid doesn't mean it's going to go to the patient. So make sure that the patient has got all the information, and the nurses are very well communicated, and then they get all the necessary treatment at the same time. And every 15-20 minutes, come to this patient, assess this patient, make sure they do all the whether they're improving or not. And it's very important um, to get other help as well. So, for example, if you have a rapid response team, or if you have an ITU team that they can come and assess the patient, make sure they're available, make sure they know about this patient, because it's very important that there's so much fluid you can give to this patient. Sometimes they may be better off having vasopressors, early intervention. They like central lines, arterial lines for close monitoring. So all these things can be arranged for these patients. So make sure you do follow all these steps. Now, when it comes to fluids, resuscitation, routine maintenance, replacement, redistribution, reassessment. Don't forget your 5 hours. If you're in the ward, your maintenance is routine maintenance is according to the current NICE guidelines is 5% hexaline with the potassium chloride in it. Okay, so that will cover your daily requirement. If you just follow the algorithm I showed you, which will tell you how much you should give and what should you give. When your daily potassium requirement is about zero point 0.5 to 1 millimole per kg per day. So if you are a 80 kilogram man or woman, your daily requirement of potassium at least about 40 millimoles. Okay. I think we are running out of time, but I'll quickly touch base on diverticulitis. This is probably the commonest colonic condition you can see in surgical unit. Um, so you, you diverticulitis essentially is outpouching coming from the bowel. Usually, so where these blood vessels enter into the mesocolon or the submucosal layer is the weakest point. That's where your diverticulum arises. Now, the most importantly, the diverticulum is only the mucosa prodding out. That means it's quite friable, and there's a high chance of this perforation, getting infection and inflammation. Quite importantly, if you get a patient with PR bleeding, the chance of them having diverticulitis is less. Now, diverticulitis managed various ways, but the commonest classification is Hinch classification. Is uh, uh, if they have mild diverticulitis, we just give standard straightforward antibiotics. But at the moment, then there's a trend going on that you can manage them without any antibiotics as well. But I think as surgeons, we are quite uncomfortable not doing anything for the patient. So current practice at the moment, everyone gives antibiotics for this patient. You don't have to give IV antibiotics to start with. They are hemodynamically stable, and their inflammatory markers are mild. You can give oral antibiotics as well. Now, if there's inflammation in an inflammatory mass, what we call a phlegmon, if there's no fluid collection, you can manage them with IV antibiotic without any problem. And if they have a pericolonic abscess, if it's a small one, you don't have to do anything. The antibiotic treatment itself is resolved, but if it's a larger collection or a larger abscess, you need to drain it radiologically, or worst case scenario, you need to wash out it laparoscopically. But majority of the time, what we do is we give antibiotic treatment and radiology guided drainage. That's why where I said when you see an abscess or when you see collection intra-abdominally, these patients first thing the radiology will ask is what's the clotting for this patient. So it's very important as a house surgery you arrange PT, APTT, or INR for these patients so that if it's normal, it's quite easy and it doesn't delay the treatment because every time you do bloods, it takes several hours. All of a sudden, you find that the patient has lost the slot for the day. That delays the treatment. For if it's a Friday, then you will not be able to do it until Monday, and most of the time, so you're delaying patient treatment. We are delaying patients' care, so that affects adversely for the patients. The way I see it is I always treat all my patients as one of my family members, depending on how good is your relationship with your family members. Um, uh, so if they're good, if you have a good relationship, I still think you should treat them as your good family members that you love and you really care. So I think do I want my mom or dad to go through what this patient is going through, then do the right thing for the patient. Okay, don't be afraid to escalate their concerns if or care of these patients. Okay, if they have generalized purulent peritonitis or fecal peritonitis, it's the time to go to theater. Okay, um, uh, I thought if I had time, I'll talk about anal fistula. This is not something you have to deal with day to day. But if someone has got a perineal abscess or constant perineal discharge, don't forget about anal fistula. Okay, this is the Goodsall's law. That means if the patient, if the fistula is in anterior, it drains radially, and if it's a fistula in posterior, like so, you have to imagine the patient's in the lithotomy position, and I'm drawing a line across the perineum, cutting the anus into half. So ideally this should be upside down. These posterior ones are always draining middle. This is very important for us to know because um, we when we what we do is we put a probe from outside and then go through and find the canal. So if you know where it's drained normally, then you know where to put the probe because you don't want to go outside like this and cause more harm to the patient. Okay. Um, uh, Again, hemorrhoids. It's again common thing that you will see in day-to-day life. One important thing I would tell you is uh, prolapse thrombose hemorrhoids. We are not going to do any operating. If you want to remember one thing and one thing only about this hemorrhoids slide, prolapse thrombose hemorrhoids, do not stick a needle, do not do anything. Well, you have to do something, but do not do anything surgical in the immediate instance. Okay, what you have to do is get some couple of insular gel and squirt over the bottom, and then you put couple of ice bags over the hemorrhoid and leave it there for about 1 to 2 hours. And usually what happens is with that, the insular gel will numb the area with the ice packs sitting will shrink the hemorrhoid. What you do is put some insular gel on the hemorrhoid, which is sitting outside, and then you just push it in like this, and it goes like very easily. And as soon as you push it in, the patient finds the pain is less. Okay, so no, one of the things A&E will ask you is, can you not snip it? Can you not stick a needle and drain the blood? Arguably, if it's present within 12 hours, you can stick a needle and drain it, but most of them that's not the case, and you can't. You will not know 100% for sure that it's within 12 hours. So the best thing is manage them conservatively. And don't forget when you do the discharge test, make sure that they refer this patient to the colorectal clinic. There's someone who's got a complicated perineal condition. you need to treat it appropriately. So make sure that the specialist sees. It doesn't matter whether you're on call for the upper GI team or a hepatobiliary team or in any other team. You make sure that you refer this patient to the colorectal clinic when you do the discharge letter. Make sure you do that. Okay. The other things you need to make sure is that the patient, when you're always answering history, make sure that the patient has got IBD history, ulcerative colitis, Crohn's disease. It's very, very important to speak to the patient whether they have got a personal history or whether they've got a family history, because certain conditions you can't manage by yourself, or they should be. So, for example, if you have a terminal ileal Crohn's, unless they are obstructed or perforated, it should be managed by the gastroenterologist. So these patients should not come to you anyway. Okay, and infectious colitis, again, don't forget when you ask the history of traveling and the antibiotic treatment, is an antibiotic treatment, etc., etc. I think I talked a lot. Let me quickly have a look at the questions. Patient is considered high stomach, but would it be appropriate to give motility reducing medication? Yes, I think I answered this one. Give loperamide. Always you can give loperamide, but the only thing I would say is if you see someone who's got ileostomy and post-operative day one, they have got a quick output of 1.5 to 2 liters. Don't rush and start loperamide. Usually, but bowel is quite forgiving. It will settle down and quickly come down. So I wouldn't rush and do start on loperamide or any PPA for this patient. But if it goes beyond day 2 post-op, then make sure you prescribe those. But most important thing from your house of point of view, I would say, is make sure you give IV fluid balance according to the NICE guidelines. Okay.
Thank you so much, Sam. That was great. Guys, don't forget to please fill out the feedback for Sam. It'll be really useful. And we've also posted the link to the feedback in the chat if you can't use a QR code. If there's any last minute questions, please feel free to chuck them in the Q&A. We may have time for 1 or 2 more before we end. But otherwise, thank you so much, Sam. It was really, really useful.
Okay. So for there are a couple of other questions. I think someone asked, right, what patient factors would make do an ileostomy instead of primary anastomosis. So there are certain things. So when we are doing an anastomosis, anastomosis, what we call, is like a marriage. Okay, so there has to be it has to be tension free, and it should match each other, and also there has to be good blood supply, so, or good life into it. So whenever we are doing anastomosis, those are the 3 things we consider. And if the patient is malnourished, or if you have experienced massive amount of bleeding during the operation, or factors such as COVID-19, if there's anything, and if the patient had chronic obstruction where you find that the proximal bit of bowel is massively dilated and the distal bit of bowel is collapsed, so then you know that definitely there's size mismatch. And the patients such as, like I said before, someone like who's got already got bowel incontinence, so there's no point of doing an anastomosis for these patients. You're going to continue the same problem. And the third group, lastly, I would say, if you have a functional gut problem, like if the patient has got poor gut motility, then if you try to do anastomosis for this patient, they won't do well. I don't know about this appropriate answer other than you should have listened. I didn't say anything like that. So in patients with considered high stoma output, yes, we did that. Okay, the lecture is finished.
Thank you so much, Sam, and thank you everyone for turning out.
No, thanks a lot for everyone. If any questions, you can forward to Kate and I'll answer, or email you if you need it. Okay, take care. All the best.
Thank
Bye.
you. Bye-bye.